As we are all aware, this dates back to 2017 NEJM article, Compass trial, where role of anticoagulants was seen in patients with chronic coronary syndrome. But the penetration of anticoagulants, the newer anticoagulants, has not been much in the clinical practice. My disclosures are none, but initially I was going to speak for 7 minutes, so I restricted my talk to salient features. As you are all aware, coronary artery disease is a leading cause of morbidity and mortality worldwide. As spoken by Dr. Hetan, CAD is a pathological process characterized by formation of atherosclerotic legs followed by their rupture, ulceration, or erosions. Plaque rupture activates platelet aggregation and the coagulation cascade, which leads to acute coronary thrombosis, resulting in acute coronary syndrome. There is nothing new which we have been knowing for a long time regarding acute coronary syndrome. Antiplatelets and anticoagulants has been recommended as a standard cornerstone treatment for CAD. But the new term which was coined and was discussed by the previous speaker was the chronic coronary syndrome, is a newly proposed identity by the European Society of Cardiology that replaces the term stable coronary artery disease. There is nothing called stable. There is something going on definitely. And this puts us at a point of concern that we should be addressing the process of coronary artery disease, which is defined as a progressive process of plaque accumulation in coronary circulation with associated functional changes. CCS has replaced stable coronary artery disease to raise awareness that despite the clinical silent nature of the disease, there are progressive pathological changes occurring in coronary arteries. With the emergence of this new entity, great emphasis has been placed on the consolidation of our comprehension of the dynamic character of the disease. Apart from the routine antiplatelet statins which we use, there is a need to add some therapies which can prevent the process of atherothrombosis. As we are all aware, three major clinical relevant pathways that amplify platelet activation and coagulation: the COX-1 pathway, which is addressed by the antiplatelets; ADP-P2Y212 pathway, addressed by the newer antiplatelet like prasugrel, ticagrelor, and clopidogrel. The thrombin pathway has not been addressed as far as the management of this platelet activation and coagulation goes, where the role of the anticoagulants are being played. Patients with established cardiovascular disease may suffer further cardiovascular events despite receiving optimal medical treatment. This is known to us because platelet inhibition plays a central role in the prevention of new events and anticoagulant therapies to reduce events in atherosclerotic disease. As we are all aware, antithrombotic therapy has been the cornerstone of secondary prevention for CAD for the last 65 years. The first randomized trial with warfarin was carried out in New York and published in 1949. This landmark study was followed by many studies underscoring the benefit of warfarin. But in 1980s, when aspirin emerged as a simple, life-saving and very cheap alternative and has stayed until today. Aspirin decreases the recurrent thrombotic events in patients with coronary artery disease or peripheral artery disease, but the risk of recurrence of events remains high. This is the point of concern. There is always a risk despite taking aspirin. Long-term dual antiplatelet therapy or the combination of aspirin and warfarin further reduces the risk of recurrent events, but at the cost of increased bleeding, and neither of these treatments reduce mortality. So, direct oral anticoagulants were tried in the various trials of atrial fibrillation, where the idea came that NOACs could be used as an anticoagulant for CAD. Direct oral anticoagulants have become available and have been studied in patients with coronary artery disease. These medications directly inhibit either thrombin or factor Xa, which contribute to atherothrombosis. As we are all aware that in 2017 in the NEJM article, Compass trial had 3 arms, but a trial arm of rivaroxaban 2.5 milligram twice daily given with low dose aspirin reduces the incidence of composite endpoint of stroke, heart attack, and death in patients with stable CAD. But still, because of various criticism that the trial was prematurely terminated, there are very critical views. Will it be beneficial? Will there be benefit of ischemic events over bleeding risk, the penetration of rivaroxaban in CAD has been poor. COMPASS offered promising conclusions of the combination of low-dose rivaroxaban and aspirin as a high-effective treatment to decrease morbidity and mortality rates in patients with atherosclerotic vascular disease. Considering the critical view of COMPASS, there were two analyses done by Sonia Anand and et al. And Darman et al., which were published in 2019 in the JACC, which reviewed the vascular risk associated with rivaroxaban plus aspirin and CAD. Anand et al., who among the COMPASS trial analyzed with potentially eligible patients should receive the combination studied in the trial. They identified high-risk patients using a modified arthromatous risk score derived from the REACH registry and a high risk for ischemic vascular events and using classification regression tree CART analysis. The high-risk features identified using the REACH score were having more than one vascular bed affected, a history of heart failure, and renal insufficiency. In the CART registry, they added the similar features, plus diabetes was added to the list of high-risk features. Proportion of patients with at least one of the high-risk features was about 50% based on the REACH score and about 60% based on the CART analysis. Compared with aspirin monotherapy, the combination of low-dose rivaroxaban and aspirin reduced the risk of composite endpoint of cardiovascular death, MI, stroke, acute limb ischemia, or vascular amputation through 3 months. There were 23 events prevented for every 1,000 treated patients, and there was only a non-significant increase in severe bleeding. So there were 2 events for every 1,000 treated. So those with high-risk features, the beneficial effect of rivaroxaban plus aspirin was seen in this analysis. Patients with high-risk features had larger event rates and thus greater absolute reduction in ischemic risk. For high-risk patients by REACH and CART criteria, combination therapy prevented 36 and 33 serious vascular events respectively, and increase in bleeding was 3 and 1 per 1,000. The lower-risk patients also similarly showed a benefit. The net clinical benefit of combination therapy increased over time, especially in the high-risk groups. Now coming to the analysis done by Daman et al., he did a multiple enrichment criteria with ischemic and bleeding risk among COMPASS eligible patients. In this, the high-risk enrichment criteria were age more than 65, diabetes, moderate renal failure, peripheral artery disease, current smoker, heart failure, ischemic stroke, and asymptomatic carotid stenosis. The more the enrichment criteria, more was the risk. REACH and CART analysis et al. Analysis shows us that in patients with vascular disease, further risk stratification can identify higher risk patients, more than 2 vascular beds affected, heart failure, renal insufficiency, or diabetes. REACH enrichment criteria of Darman et al., the analysis from REACH registry is consistent with the findings by Anand et al. Of late, there has been an analysis of the COMPASS trial of the Asian component of that. Asian compared with non-Asian patients with chronic CAD also showed a benefit, but there was an increased risk of intracerebral hemorrhage. Now, NOACs combined with antiplatelet drugs in the treatment of coronary artery disease, a systematic evaluation and meta-analysis also shows the benefit of NOACs with aspirin in the treatment of patients with CAD. Now, anticoagulant therapy for chronic coronary syndrome, the point which I am trying to press is, patients with stable CAD remains a challenge to treat as they remain at increased risk of further cardiovascular events. Maintenance therapy with single antiplatelet is the standard of care for secondary prevention of atherosclerotic cardiovascular events in patients with CCS. But the ESC guidelines and the NICE guidelines recommend the use of NOACs, rivaroxaban plus aspirin in high-risk patients of CAD, which I enumerated by the enrichment and the CART analysis. To start off, get anticoagulant therapy for chronic syndrome, in which direction is the COMPASS pointing? To start off, we have to get comfortable giving patients rivaroxaban in a high-risk group. The considerations to be done are there can be increased risk of intracerebral bleed, the cost factor, and the drug-drug interactions.
Dr. Ghosh, please conclude.
Yes, sir, last thing.
Time is up.
Clinicians may take time to apply the new recommendation, particularly in primary care. Increased interest in targeting other upstream factors in coagulation cascade is in the recent advances. There are inhibitions of factor 10 and 11 in pipeline which have very minimal bleeding risk. Thank you.